bring you up a little bit. There we go. Guys, I think we're live. Oh, that's too high. Go down a bit. There we go. Guys, I'm going to kick off today's live session talking about anterior pelvic tilt. That is whereby we are sticking our bum out and we have the pelvis rocking into anterior tilt. This is going to create shearing specifically at the level of the L5S1 and is something that is bandied about the place terribly frequently for those with back pain, right? You go to your physio, your chiro, your osteo, whoever it is, and they say, hey, you got some anterior pelvic tilt. You need to tuck that in and progress on. We see this kind of used in exercises like Pilates, where you get told to tuck the pelvis or pelvic tilt to flatten your back to the ground when you're doing certain core exercises. And it's really something that is terribly misunderstood. And hopefully this next little bit before I get to your questions, guys, will really help you guys understand this once and for all. The first and most important thing to understand is that you should assume that you have a normal, natural lumbar spine. It might be injured, but the alignment of it in the standing position is normal unless you've been measured otherwise. And what I mean by that, what is a normal lumbar spine? A normal lumbar spine is a pelvis that is on a certain tilt, right? And that is reflected in the angle of the sacrum that the lumbar spine sits on. And so the pelvis is aligned like so. And then the lumbar spine has a smooth lordosis. That is a backward bending curve that goes through it so that it is not straight. The spine in the lower back should not be straight like so. It should be curved. And what you find when it is aligned correctly is that the midpoint of the curve is over the hip sockets. When it is aligned flat, and this is a posterior pelvic tilt as opposed to an anterior, the spine, the hips are away forwards, right, of the central spine. Why is this really important? Because if you don't actually have an anterior pelvic tilt and you start doing things to correct that anterior pelvic tilt that you don't have, you're going to end up creating more trouble than you want. And I'll maybe get to some other bits later on about the posterior pelvic tilt and why that's more likely, etc. But assume that you are a normal human being with a normally aligned lumbar spine unless it is measured otherwise. Now, how can we measure this? The only really accurate way to measure this is going to be through a load-bearing standing image of your lumbar spine on X-ray. When we lie down and have our MRI imaging, we can get some kind of cues as to the potential positioning of the lumbar spine, but it is significantly inaccurate. And please bear in mind, I'm talking about this from experience of literally over a decade, talking about 12 years plus now. Every single patient, for a significant majority of that time, of the thousands and thousands of patients, and then obviously members as well on top of that, but patients in clinical practice had the presentation with X-rays alongside them. So you get very, very accustomed to seeing the patient with the lower back pain and the sciatica, the herniated disc, etc., and seeing their imaging alongside that. And that's a very important point because more or less everybody that has been diagnosed with anterior pelvic tilt has been seen by a practitioner that does not have that experience. They've worked in a clinical practice, as great as that may well be, but their specialism is not in that kind of level of spinal analysis. And therefore they haven't had the rather painful, I will say, and humbling experience of starting to realize that all these commentary about spinal alignment that you might be able to observe from the surface of the skin are basically of zero value, practically speaking. Yes, we can make some great observations of my knee joint and the positioning of my knee joint and whether I'm hunched over like so or leaning back like so in the physical exam. But you don't have a clue what's going on in this spine. Why? Because it's all the way in here. You can't see it. So you get the kind of comments that constantly lead to you guys going off in tangents and getting confused and making things worse by saying, oh, look, your bum sticks out. Oh, you must have an anterior pelvic tilt. Oh, your tummy sticks out. You must have an anterior pelvic tilt. Now you can have your bum sticking out because you have glutes. You can have your tummy sticking out because you're not engaging your lower abs. And so if we start to use those as a need to, oh, you've got to tuck under and in, you're just changing the position of the body and it's actually making you worse. You had a perfectly normal spine. So for example, with the commentary about the glutes, if the glutes are coming into the conversation about your lumbar spine alignment, the person is not very good from an anatomical point of view. The glutes have nothing to do with the observation of your curve. Why? Because if I take the point at which my PSISs are at, which is right here where my thumbs are, for reference for you guys, that's here. My lumbar lordosis is the lumbar lordosis, not the sacrum and lumbar lordosis. It's measured from L5 to L1 or L1 to L5. So any observations from here and down are useless when we're talking about the lumbar curvature. Very, very important. And so my bum might stick out a lot or not a lot, but where my lumbar curve starts is going to be above those bony points, so around about here. And you can see that there's not a lot you can observe. Okay, now my lats stick out. So based on the muscle mass of the individual, based on the glute development of the individual, we can get these illusions that have absolutely nothing to do with whether you have an anterior pelvic tilt or not. If I stick my tummy out like that, and then I draw it in, oh, now I don't have anterior pelvic tilt. Now I do, now I don't, now I do, now I don't. None of that changed my alignment. And so you might well have your tummy sticking out, and you should engage. And you might well have big buttocks, right? Great. But that doesn't have anything to do with your lumbar curve. And so using that as a surrogate to then say, oh, you've got anterior pelvic tilt, now do some posterior pelvic tilts, that is a real problem. And that's why so many people really struggle to actually get any meaningful improvement. Because actually, when you've had the experience of seeing a lot of these people, you find actually it's more likely that you have a reduction in the lumbar curve if you had any variation from the normal. And I do stress, it's most helpful if you assume you have a normal, healthy lumbar spine until proven otherwise with numbers. And if that's the case, you crack on and you focus on just a normal alignment. You don't need to worry about it. Yes, you want to have your rib cage stacked over your pelvis, your head, over your shoulders, and that's the level of postural alignment that you need to worry about. Forget about pelvic alignments and all that kind of stuff. It's not necessary, and it's just confusing. And unfortunately, these guys that are telling you that are confused themselves because you've got blind spots, right? You don't know what you don't know. I don't start talking about wrist rehab because it's not my expertise, but I do have a very detailed experience, significantly so, in the lumbar spine and these kind of problems, and you start to see these things. And so when we think about, well, what causes alignment changes in the lower back? Because one of the things that we used to do in clinic, we don't do it so often anymore, is because is spinal remodeling. And spinal remodeling is where you change the person's structure. So verifiable, and there's a nice video on the YouTube channel of a before and after of one of the patients, well, two patients, one a neck example and one a lower back example, of the lumbar curve alignment change that's possible. And it was over about a 3 to 4 month period. It might have been 4 to 5 months. And you can see a significant change in the lumbar curvature, the lumbar lordosis increased. And what you see is, how does that happen? You change the person's lumbar curvature by putting them in a set position for an extended period of time. I actually have what you use. This is one of the devices. This is called a lumbar denerol. You just lie over this thing for 20 minutes a day. Now you can see, those of you guys that have seen me talk about the towel, and this is not an endorsement for changing your spine, by the way. Those guys had had it measured before and after, and you see the measurements on that particular video. But you lie over this, you place it in the right spot, and it creates a traction through here, a decompression, but it also helps you get a remodeling effect, and it works over a 3 to 4 month period. And what I'm trying to illustrate here is to help you guys understand how remodeling works so that you can understand why it's so improbable that you've got an anterior pelvic tilt. Putting someone on that thing for 20 minutes a day, and that's it for 3 months, only 3 months for 20 minutes a day of passive stretch, allows the spinal ligaments to change such that when you stand that person up, not right after doing it, but normally, they have a change in the lumbar curvature. And the same can be done for the neck with a slightly different device. And so that's just 20 minutes a day for 3 months. Now, what does everybody do for significantly longer than 20 minutes a day? They sit. What are they doing when they're sitting? They're slouching. What are they doing when they're slouching? Flattening out the lumbar curve. And they're doing it for longer than 20 minutes a day, and they've been doing it for longer than 3 months. So you can see how, based on my experience over those thousands and thousands of x-rays of patients, real people with real back pain and sciatica, how it's understandable or explainable as to why, if they had any variation in their alignment, it was more likely to be that they had a reduction in the lumbar curve than an increase. And the amount of times someone will come in over the years and say, oh, I've been told I've got anterior pelvic tilt, look. And then you go and x-ray them and you see, you don't have an anterior pelvic tilt. You've got a posterior pelvic tilt. Your spine is actually reduced by 27.3% or 35.7% or whatever it may be. But we gave numbers. We talk about numbers. So if we're going to change anything, if we're going to say we have an anterior or posterior pelvic tilt, and we're implying that this is actually an anatomical variation for this particular person, we need to have numbers, not just a physical examination, because physical examinations might be great for looking at the elbow bend, but you can't see the spine. So hopefully that's going to be helpful. Guys, if you've got any other Any other questions on this? We'll go straight into those now. Oscar said, I did the dead bug itself again today and I got lower back pain, sore after 1 hour. Is it normal? Oscar, what were we getting up to after the dead bug? How many reps of the dead bug? And I was just, the next step is to try the easier version of the dead bug. Try doing the half rep dead bug. Try doing the quarter rep dead bug. What we need to find is what can we do without the aggravation? What can we do? And then build back up from there. Very important starting point, Oscar. What else have we got here? Best way to sit, so B3GR8, be great. Is there best way to sit down if I get tired sitting up straight? What can I do to support while I sit? We talk about a couple of things, using a towel in the lower back. Make sure you're sitting up straight, take a break, recline, those kind of things can really help. Carrie said, I have severe back pain, it came on randomly came on yesterday. I can't get out of bed and walk. Often, unfortunately, this is the way these things set on, right? We don't think we've done anything particularly significant, but we start to feel maybe a little bit of an ache, and now it's back pain. And Carrie's having to think about, over the last week or so, maybe longer, have we had back discomfort, back aching? Now, for ladies, it could be potentially associated with particularly bad period pains. It could be something like that. It could be that I know we were speaking to someone the other day, they'd had a bout of food poisoning, and that kicked things off, right? They'd irritated their back a little while ago, and then they had a bout of food poisoning, and that made it a lot worse. That could be something. It could be the repetitive strain. Most people do not get a back injury or back pain or sciatica coming on after doing something crazy like a 100-kilo deadlift or squat. They get it after, quote unquote, what feels like nothing. And nothing isn't nothing. Nothing might well be sitting for extended periods. Nothing might be walking the dog and getting pulled off in a different direction. And if we're so very weak and vulnerable, then those kind of things can push us over the edge. So it could be a number of different things. The most important thing we do now is doing work such as starting to do some of the core relief work that we talk about, calming down the area of inflammation, having a look at any aggravating factors, those kind of things, and seeing if we can make it worse. That's always a helpful thing. Oh, if I do that, it makes it worse. If I do that, it makes it better. Sometimes, often, we want to watch out for things like, oh, if I hug my knees, it feels nice, it feels better, but that's something that's making things worse invariably. And having a look at some of the other resources that we've got on the program or on the website would be a really great source. Carrie's having a look up in the link in the profile page at some of the things we talk about. Some of the playlists that are in the profile page on the TikTok account would be a good starting point, but basically everything we talk about is really important. Carrie said, I had a muscle ache in my right glute, but it wasn't bothering me. And this is the thing, right? Back pain isn't bothering us, or back injuries aren't bothering us until they are. And that's a problem that a lot of us face. We ignore it until it really bothers me. And so what's most likely happening in Carrie's case is that there's some kind of minor disc irritation, maybe a minor disc strain, disc bulge, something like this. And it's been bothering her for a while, but it's been ignored. And gradually, this disc is breaking through the layers of annulus. And yesterday, because of the sustained stretch, not doing too much of anything, but it was just a bit weaker, and it just broke through one of those extra layers. And now we've got a lot of inflammation down there. And what will probably happen, generally speaking, is it'll settle down reasonably quickly if we adjust what we're doing and we do the right things. And then we go, it's not bothering me anymore. And then we carry on. And we don't actually do the rehab. And that's the cycle that so many people go in, from one flare-up to the next, to the next, to the next. And it gets worse and worse and worse until they really hit a rock bottom level. And they're like, I need to do something about it. And so even in this question, this microcosm of an example of this in Carrie's case, like I had back pain yesterday, I hadn't done anything, implying that it's only started yesterday. But even from the second comment, we can see actually it's been going on for a bit longer. Unfortunately, you guys don't know because you don't know what you don't know, right? That very frequently, because of the nature of things down here, we will get glute pain, we will get leg pain, we will get piriformis or buttocks pain. And so often, so many of you guys will go from pillar to post trying to get relief for the buttock pain for a long period of time, and then only to realize 18 months down the line, it was a herniated disc all along. Because we keep on doing stuff to the buttock where it hurts or ignoring it, and actually it's not really going anywhere. It's just kind of settling, if you will. Kyla has a large, lost that. I've been told I have osteoporotic vertebral collapse. Doctors have given me pain meds and no explanation. Becky, you need a good bit more explanation than that. I think they're implying that you've got significantly reduced bone density and that the vertebrae are collapsing, as is obvious when you say vertebral collapse. You need a bit more guidance and support, without a shadow of a doubt. Why? Are we going through menopause? Are there other that has the implication that there is some kind of bone density issue, so you need to get on top of that and get some answers in that regard. Can you show us how to do a proper sit-up? You don't do a sit-up. Be great. I know you've been watching a couple of our live streams, so a sit-up violates the principle of a neutral spine, so we should not be doing a sit-up. Sit-up is not one of the exercises that we advise. You're just going to be maximally compressing through the disc, and there's no real value in that kind of exercise. Check out some of the other bits and pieces that we've got in the program, such as the Core 5. That is going to be a great place. And if you're struggling, guys, if any of you are struggling with your back pain, with your sciatica, definitely check out the link in the profile page, because there's so much there to help you guys. And if you need more help with an actual structured program, rather than trying to piece together exercises, hey, try a plank, hey, try this, hey, try that. Don't try a plank, by the way, and don't try a sit-up. There's a program there to help you guys go through. And then, you know, you can ask questions about that kind of stuff. Christian said, I've got a bruise feeling in my lower spine 6 months after injury. Is that normal? Christian, unfortunately, we see too many people over the years that have a back injury that doesn't get dealt with correctly over a long period of time. So the question I always ask, whenever someone says, hey, I've got back pain, I've had a back injury, I've had it for this long, like, is that normal? And I say, what do you do on a hip hinge? What do you do on a squat? And then I say, well, I'm not doing those. I've just been trying to leave it. I say, okay, well, then you haven't done the rehab. So we've got to do rehab. Rehab is super, super important for you rebuilding resilience in these injured areas of the lower back. It's very, very important. I would argue it's essential. It's essential. Straightening of the lumbar spine with loss of lumbar lordosis, would the towel decompression be suitable? The towel decompression is suitable. The reason the towel decompression is such a prominent exercise was partially from that experience that I was discussing earlier on in the live session, but also because it's one of the antidotes for stress and strain of daily life. All of us, including myself, are sat here, sat down, and there's going to be an element of flexion through the lumbar spine, and the towel is an opportunity to provide an antidote to that, an opposition to that, dusting off the cobwebs. And so it should be done daily. It's not an intensive exercise. It's not like using this thing, right? It's much more gentle. It's just supporting the natural healthy lordosis, but it's certainly worth doing. Oscar's asked on YouTube, is the farmer's carry a safe exercise? Oscar, you might have seen some of the videos. We talk about the farmer's carry at like the phase 4 level of the program. I think it's a great one, but I think you're better off right now actually scaling the squatting and or hip hinging load as the primary mechanism for driving load through the lumbar spine. It's just a little bit less variable, let's say. So that's where I'd go, and I'd build up to certainly well towards that 100% of the body weight before we start adding in other stuff. One of the things that there's different ways we can perhaps challenge ourselves a little bit more. In the rehabilitation space. And this is much more later rehabilitation. For those of you guys that are struggling right now, this is a little bit different, right? This is further on in the process. And one of the ways is obviously doing the exercises, 5 sets of 10, that kind of stuff with the squats and hip hinges like you're doing. But another is increasing the volume, doing more stuff, right? Throwing in some farmer's lifts, farmer's carries, etc., that kind of stuff. And you've got to be very careful, because it might be that actually you're capable of dealing with X load for 5 sets of 10 reps, but when you start doing X load and then bouncing into farmer's carries and then bouncing into some other exercise and then bouncing into, we're doing too much, right? And there's this temptation, I think, something that I've certainly experienced recently, maybe over the last few years of training, that less is actually more in some cases, in fact, maybe a lot of cases, especially, Oscar, someone like yourself, where you are actually quite busy, you're quite active during the day anyway. I think you need to have, just given by the nature of your occupation, you need to have a hard session, but it needs to be focused and then done. And then once you get to the point where you feel like progress is starting to slow, sure, we can go and look at those other things. But generally speaking, in the recovery process, especially of people that have a background in training of some description for their lower back recovery, generally, the muscles have no problem getting stronger. And actually, it's the discs that we end up overstraining by pushing ourselves to do too much too soon. So I would be careful about adding in extra spinal loading stuff. Do the spinal loading stuff hard in the instance that you're doing those essential workouts. And then the additional workouts, you'll notice, Oscar, that we've just released or are releasing later this month, the end of September. We're releasing a bunch of additional workouts. Those are all like low load spinal exercises. They're stuff to do to still work out, but not to load the spine, rather than adding in more spinal loading, which I think might well be more unnecessary, particularly in your case, Oscar. So it's just something to think about. This less is more concept. Brother, you're not reading comments. Pickford, I've got like a ton of comments coming in here. You might not still be here by now, but yeah, they're coming in so fast. I'd be bouncing off and having a bunch of inconsistent or incomplete answers if I was replying to the comments all the time. So I kind of come back and go through them and then go back through them again. What other comments have we got here? Are you a physio in London? No, I'm an osteopath. By training. Should I get imaging done if I'm improving, or is it a waste of time? Never got a diagnosis. So personally, I feel like imaging is really helpful. So you guys will know if you've been following the channel for a little while, because I talk about it frequently. Back in June, I got a tear of my meniscus, medial and lateral meniscus. during jiu-jitsu, right before a competition. And I knew I'd had a torn meniscus, right? You know you've got a disc bulge, you know you've got a disc herniation. The MRI tells you and told me the following Monday after the Tuesday that in fact it was this scale of, there was a flat tear on the lateral meniscus and there was a tear of the posterior medial horn of the meniscus and a few other bits of commentary. Good news was all the ligaments were intact, which is fantastic. But it told me exactly what was going on. Did that change my rehab? None. It didn't change my rehab one bit, not at all. However, I personally feel that the £400 I spent to get the MRI done was actually really well worth it because it gives me a snapshot of the status quo right now. And so long term, I've got that image of this is what it was like here. And so I can compare. Often one of the things that people want to see is, well, what's changed? What's changed? And the same thing with blood tests, for example, right? Having a log of blood tests over time, of imaging over time, I think is very helpful. And so it's then a decision is, do you want that wisdom that comes from understanding your body better at the cost of £400, which is around about what it might be if you get an MRI done, or do you not? Because it's not going to change your rehab. That's the important thing. And if you've got someone that can be helpful, like we have members share their MRIs, share their x-rays all the time with us in the members area, right? And we help give them a bit of insight into that, answer any questions they might have. Oh, what is this bit here? What does that say? What does that mean? Et cetera, et cetera. And so that can be really helpful for some people that are inclined to want to know that. Others, they don't really care. They don't really care. I just want to get better. That's all that matters, and I don't really care. And so whichever category you fall into, that's the value of the MRI. If you're getting better, well, that's fantastic, especially if you're doing the rehab work. And by getting better, you mean I'm able to progressively bear more load through my spine, as is demonstrated in my rehabilitation exercises. And if you can say that, the imaging isn't going to change anything, but it might help you understand what has gone on and have a snapshot of your general health and well-being right now, which I think can be really helpful. What else have we got here? I have got pain on my lower back, right foot. It's been 2 weeks. All the stuff we've been talking about there, Pickford, is going to help. It's going to be helpful. Never had imaging done, never got an official diagnosis. Again, most of the time, if you're a sensible and reasonable clinician, when you're referring someone, you already know what's going on. Like the meniscus issue that I'd had. Like when you refer someone for imaging, you're like, it's looking like it's going to be a disc, and then you're like, oh, it's a disc with this, or so, there's a little bit of facet degenerative change, and like that's useful, right? Because if you think you've just got a disc bulge, and then you see, oh, there's some degenerative change in the facet joint as well, it gives you an understanding. Because if you've only had this problem for like the last 2, 3 weeks, 4 weeks, 6 weeks, or something like that, and then you get the MRI and you're like, oh, there's a disc bulge at L5S1, but we've got some facet joint hypertrophy at L5S1 as well. It makes us realize that, you've been putting strain through the body in this particular area in a significant way, more than all other areas, for an extended period of time, long before you've actually had the pain. And that tells us, like is almost always the case, by the way, that most of you have been getting away with not having back pain in spite of the weakness and vulnerability that's in your back. And actually, I said this the other day on the live, I think, there's so many videos that I forget sometimes, that for some people, actually having that injury is a blessing because they hadn't been devoting appropriate amounts of time to the resistance training and keeping their body in good condition, objectively speaking, with objective measures that they can refer to. And actually, they come out the other side of the herniated disc and they're like, I'm changed forever. I'm always going to continue to do some element of resistance training for the long term. And they will benefit immeasurably in their general health, in their mindset, in their mental well-being for the long term by getting into that. And maybe that injury to the disc was a segue into doing that. I think certainly as individuals like myself, I've always taken it for granted that you need to do those things for the long term. It's always been part and parcel of what I've done. The longest period I've ever had not working out, not doing something, has been during that COVID period. And even during that COVID period where everything was shut down for 3 months, I still took over to running. Carefully, of course. Started just running around the block, short distances, right? To do something. So for some people, it can really be, for many people, I think, it can be a real blessing, actually having that herniated disc. As bad as that might feel right now, you guys won't be able, you'll only be able to appreciate that retrospectively. Leo said, thoughts on how much harmful or generally bad information is being produced and consumed when it comes to health and fitness, and people like you, Belly. Oh, yeah. I mean, at the end of the day, you just do what you can to put out educational content and, taking questions. Yeah, everybody's got a voice. And hopefully, the longer you listen to a voice, the more you put it under scrutiny and the more you can realize whether this is a voice worthy of listening to. And hopefully, you guys feel that, what I'm talking about makes sense. It's communicated effectively to you guys. And across the, the thousands of videos that we've done now, it's helpful for you. You know, I don't really like, I know there's one of the things that I really don't like on social media is this constant like, so-and-so said this and look how stupid they are, or so-and-so said this and look how wrong they are, and so-and-so. I don't like the going after people, because I think people are just using that as a way of growing their social media, and it creates a very negative space. So I think the most important thing is say, this is really good stuff, and this is an argument, this is a specific commentary, like do a knee hug, and then you explain why someone might want to do it, why someone might have been recommended a knee hug, but here's why I don't think it's a good idea, because it's not going deep enough in X, Y, Z, right? So the knee hug is a great example, and I may as well cover that with you guys while you're here. The knee hug is bad if you have a herniated disc, but it feels good. Why does it feel good? It feels good because for most people with the herniated discs and the sciatica, there is inflammation that is accumulating around the injury in the lower back. And so when you bend forwards, you increase the space where my little finger is, where the nerves come out, and that creates this kind of release valve, which releases pressure, and why it feels nice in the moment. But it comes at a cost of you driving more pressure through the front of these discs, and that drives the disc backwards, and it strains these tissues that are trying to knit back together again. And so we're doing something that feels nice, but actually is making the underlying problem worse. Going back to how I started this live stream, talking about the experience and working with these things, the people that are recommending those exercises, I was taught to recommend those exercises at university as an undergraduate osteopath. So I'm very, very sympathetic to why you might do that. But they just haven't gone down the specialist route that others have gone. They haven't had the experience that others have gone. So their proviso, their philosophy is that your back pain, your sciatica is the problem. And I would say no, your back pain and sciatica is not the problem. That is a problem as a consequence of the injury. And so when we talk about coming up with rehabilitation, we come up with things that prioritize the injury rather than just the symptoms. And so if you're prioritizing the injury, you wouldn't recommend a knee hug or child's pose. And so that helps, hopefully, you guys understand why certain practitioners who are prioritizing your back pain, your symptoms, your sciatic pain as the problem, it's perfectly reasonable for them to recommend the knee hug and child's pose. But that's not the problem, that's the symptom. And they just don't know. And so when you start talking about it in more detail, you go through either a painful process of having to shed off some of your existing knowledge and reconstitute that knowledge, or you dig your heels in and say, no. It's up to you. But I will say it was a painful process, because you get taught by these people that you look up to as university, and then you realize in practice, oh wait, this isn't the complete picture. Like one of the exercises, I just cringe at it now. Everybody loved it. When we were student undergraduate osteopaths, everyone loved it, right? Reinforced flexion, right? So the person lies on the bench, and you come over and you do reinforced flexion. So you put your forearm on the sacrum like so, and it creates a really nice lever, and you pull around in this direction, and it pulls that flexion into the lumbar spine. It creates loads of space. It feels really nice often while it's being done, right? But I just realized, gosh, with all the knowledge that you get postgraduate and you experience with seeing these x-rays, that was so wrong. But that was taught at probably the premier osteopath training institute, which is now called the University of Osteopathy, I believe. It was British School of Osteopathy at the time. And they were teaching that stuff, right? Not good. On that topic, I can't read the name out, but it said, what do you think about the Jefferson curl? I think the Jefferson curl has absolutely no place in the recovery process. Now, I went to, as you guys know, Simplified Strength seminar with Sean McInroy, the Australian guy, who's very, very friendly, cool guy, funny, a good guy, really good seminar, and very, very strong. And I discussed with him briefly about the Jefferson curl. Those of you recovering from back pain have no need whatsoever to do the Jefferson curl. I think the Jefferson curl is, we have to understand and appreciate, everybody wants to do fun stuff, right? It looks cool on Instagram. If I go over here, right, and pick up this 80-pound kettlebell, and I go, oh, look, I can do a Jefferson curl, and I can round my lower back, and I can go all the way down, and I can come all the way back up, and oh gosh, my back's so strong. Like, that's irrelevant. It's it might get views, right, and you get some of the, but it's sensationalized, and like, I don't have a herniated disc. But again, people that recommend that when people have a bad back don't realize how the spine functions. It's not the same as other joints. It's not the same as other joints when we injure them. We don't have conscious control over the L5-S1 segment that is herniated, or L4-5. It's not how the spine works, but that segment is compromised. And so when you're just pulling everything, I always use the example of a flexible light or lamp, where you pull it and then the whole thing bends because it's got like a flexible cord on it. And it's a bunch of joints that just bend, right? And we just pull one end and the whole thing bends. And that's how your spine normally is, right? When I bend my neck, all the joints should be moving equally. And where they're not, well, We'll talk about that another time. So if you've got an injured segment in there, as you bend the light, the injured segment is going to be wobbly, and all the movement is going to preferentially go through the path of least resistance, because the way the spine works is that there is a ton of ligaments that we don't appreciate here that hold the spine in its resting position, as I mentioned with regards to spinal remodeling. And so when we bend one way or other, those ligaments, if they are all in their appropriate tension, will then allow the spinal bones to move one way or another in unison. But if one section is damaged and vulnerable, it's now going to bend in an atypical manner, and you can't predict that. So from a training point of view, what is really important to make progress is that we have an understanding and appreciation for the current status quo. I can bear 35 kilos of load on my spine doing a squat for 10 reps. With the Jefferson curl, you have no means of really, in a refined manner, having an appreciation for just how much movement or strain is going through particular tissues. As we bend the vertebra forwards or backwards, the amount of strain on the posterior part increases dramatically in a way that is, I would argue, non-linear and very difficult for us to predict. Whereas if we just increase the strain on here with a different amount of load, i.e. using 36 kilos instead of 35 or 34, we can predict the kind of strain that's putting on the tissues much more accurately. So it makes for a smoother process. Now, are there people that are on the internet that swear by doing the Jefferson curls? Fantastic for them. That's great. I wish you all the best. But we're looking at about creating the smoothest possible pathway to rebuild strength. So we talk about doing neutral spine. That's what you guys with back injuries need to focus on. And when you've built up a strong, healthy, neutral spine, you'll be able to move in all directions. You don't need to add in a Jefferson curl. You don't need to. We talk about the adding inflection in a specific episode of the podcast, which helps you guys understand that. But what the reason people want to do it is say, well, strengthen in all ranges. It's like, fine, strengthen in the neutral ranges first, right? And yes, if you are not someone with children, with a job, with other commitments, with hobbies, and you want to spend 17 and a half hours in the day, I'm being a bit hyperbolic, understand, in the gym, doing all sorts of different things, sure, throw in some Jefferson curls, right? Sure, go ahead, right? If you've built up an appropriate level of strength. For me, there's probably a good case, right? Because I'm doing jiu-jitsu, there's a good chance that I might be in a funny position like so, and a 100-kilo guy jump on my back. So actually strengthening up in that range is a sport-specific thing. But build the foundations first, and then start to get sport-specific. Then start to say, do you know what, I'm going to start, and you'll see some of the guys, like in the jiu-jitsu space, I can think of a couple from online right now, that are like in the jiu-jitsu space or other space and like strengthen in all ranges, strengthen in this position, do sled pulls in this position or this position to strengthen those tissues. But those guys have the foundations first. Why are we worrying about the sexy stuff when we're struggling with a herniated disc on the left side and we can hardly bear on both legs? It's just putting the cart before the horse. And rather than focusing on simple stuff, which is what attracted me to the Simplified Strength Seminar by Sean, rather than focusing on the simple stuff, people want to get onto the juicy stuff. It's not even necessary. And I'll finish up and then I'll go back to some more questions on here because I can see a good couple coming in. I hope it's been helpful for you guys. Rather than trying to focus on other fancy things, get your basics in place first. And if you really find you've got tons of time, go ahead. Because many of you guys that have either sprained a wrist or sprained an ankle will have been through this experience because you get told your spine is stiff, you need to move it. Move it when it's healed. Move it when you've got objective strength. Because if you've ever had a sprained wrist or, like for example, my knee, right? I keep coming back to my knee because it's relevant, right? Or a sprained ankle. It's stiff, right? It's stiff when you're bending it because you've damaged the ligaments and there's lots of inflammation there. But you know what happens? As it heals, you all of a sudden can move again. Now, some people, if they really mess things up and they go through a bit of a chronic deviation process, they need to do a little bit of mobilization work to get it back. But most of the time, the body is really smart. Our body is actually fantastic. And all of a sudden, or over a slow period of time, those ligaments heal up and oh, I can move my wrist again. Oh, I didn't need to do any specific mobilization work. It actually just healed. Funny that. Go figure, the body's intelligent, you know? So what you'll often find is the stiffness will go when your back heals and you don't need to do the explicit stuff. And the final point is that if anything, you probably need to do something that's focused on extension because you're going to spend, in spite of your best efforts, more or less all of your day in some degree of flexion as you're sat on the chairs, etc., etc. So you probably don't even need any more flexion. And I'll leave it there because I can see so many comments coming in. So I'm going to go back through the comments, guys. I've got Owen, is it a good idea to do core exercises very early in the morning before I go to work? I don't think so. Oh, I mean, you might find, so some people find doing a little bit of like maybe some dead bugs or something like that to activate the core at certain levels of your process, of the recovery process, can be helpful in kind of creating this pump before you go out, and then you do a proper workout later. We have members all over the world that have all sorts of commitments, all sorts of jobs. You know, some people are working nights, some people are working days, some people have whatever, right? So the most important thing is that your rehab stuff gets done. Rehab as distinctive from relief-based work. The most important thing is that it gets done. Now, if you find that actually doing a little bit of just a few dead bugs, right, before you leave out the front door to provide a bit more stability, then fair enough. But what you'll probably find, if you're finding that pain is worse in the morning, is actually just doing the relief-based stuff that we talk about is actually a better use. Moving around a little bit, because often it's inflammation that builds up overnight in these areas that creates the pressure, that creates the stiffness and the pain, maybe the sciatica down the leg. And as that settles down, as you start moving, going about making coffee, that kind of stuff, it should start to ease off. So I'd look at relief-based work generally, rather than doing your kind of rehab work or core work. I'd focus on doing that later. Leo, thanks for the comment on Jefferson curls as well. Appreciate that. So going back through some of these comments on TikTok, guys, if you are on YouTube as well, you got any questions, post them in. We are running at 36 minutes. I've got 25 minutes left with you guys. Hopefully this can be really, really helpful. And I appreciate all the little hearts that are coming in on TikTok. Thank you. So I'm suffering with serious chronic pain. That's a little bit more difficult. Jane, I'm sorry. I mean, start with some of the stuff we talk about, but yeah, there's a lot there that I probably can't unpack right now. What's your opinion on walking in the pool? KK has said. So people often say go and do swimming if you've got a bad back. Understand what the role of swimming is. And I do say, one of the things I specifically say is, like, if you want to go into the pool, if you're struggling with lower back pain, just go and walk around with a friend and have a chat. Why is this good? It would be in the category of relief work, meaning it is not providing any cumulative benefit of substance. It is an opportunity for you to take pressure off the spine and give it a break. And walking around having a chat with a friend for 20 minutes sounds perfectly reasonable. However, you have to ask the question, are you at a position where you're able to go to the swimming pool, right? So if the actions of getting in and out of the car, getting changed in the changing rooms, walking around, dodging that kid that was running past, that might not be worth the little benefit that you're going to get in a swimming pool. And so maybe it's a case of actually make a bit more progress on the rehab front first, and then you can leverage that as a smart strategy for the long term. If you've got a swimming pool in the garden, I know, if you live in certain climates, say Florida or something like that, it's not uncommon for people to have pools in the garden. By all means, go and crack on, right? Because you can just walk out of your house, go straight into the pool, and come back out again. But if you're spending time to go to the public pool for something that is relief-based, I think it's probably not worth it. Focus more on your rehab, and when you're feeling better, you can then consider those kind of things. Lily has said on YouTube, I have herniated my disc in childbirth 12 weeks ago. That's tough. That's really tough. Obviously, I'm active during the day, but unsure where to start with movements and how to incorporate them into my day-to-day. Congratulations first, in terms of the babies. And I would say the most important thing is you do your best, right? Because you're a great example here, one to watch out for, Lily. You're putting the baby down in the cot, let's just say. You're doing this, right? What that's doing to the lumbar spine. We sometimes get members that are in the program that are parents, just like Lily. And maybe they've herniated the disc before or whatever. Maybe it's the dad, right? And they just had a newborn. And they're like, I don't know why, but my back pain keeps flaring up. My disc keeps flaring up. I'm not doing anything, right? I've only, and then we're like, oh yeah, well, I've got a 6-month-old or a 12-week-old or whatever it may be. You're like, you're not doing anything? As a parent of a 12-week-old, you are doing so much every day, and lots of it is not good for the lumbar spine. And so one of the most, and you're rushed off your feet trying to look after them, especially if you've got 3. We've got 2, you've got 3, so I can appreciate that 3 is probably going to be even more of a challenge than 2, right? And depending on how old the other 2 are, Lily, I don't know, but it's going to be tough, right? But focusing on principles, like the principle of a neutral spine, trying your best to hold your spine steady, practicing some of the exercises like the core 5 that we talk about and the exercises that we talk about in the program to build some degree of control in midsection. Because you're going to be carrying that little baby. If you're breastfeeding, all that kind of stuff, you're going to be carrying them regularly, putting them in and out of the car. All of that stuff is strenuous. So you need to quickly skill up as quickly as you can in terms of learning movements like the squats, right? Like the hip hinges, in a way that stabilizes your spine so you can build that ability as quick as possible and then start progressing through the rehabilitation and just have this appreciation that there are going to be flare-ups along the way, right? Because of what you have to do every day. You're going to always put you behind the babies. And so in terms of priority, so you just do your best And steadily, as you start playing catch up and improving your competence, the good news is your body's going to heal, right? It's going to go through a healing process. And just being a bit more aware, using some of, for example, the educational resources we have out on the YouTube channel, but more importantly in the program, to help guide you through this process and skill up as quickly as possible. And just take, unfortunately, you've got to just take the flare-ups on the chin and don't think there's anything wrong with you in that regard. It's just the fact that you're in a more vulnerable situation. And just continue to progress on with the rehab and build strength and resilience, you'll start to notice that you start to become less and less vulnerable. You start to have flare-ups less and less frequently, and you'll start to really gather some steam. So it is difficult, you know. If we're pregnant and we have a herniated disc, if we've got little kids and we have a herniated disc, you know, those are really difficult scenarios to be in. But all we can do is all we can do. And from experience, like, it's tough, it is, but you can get better. You just have to be really, really disciplined, you know, at a time when it's really hard to be disciplined, you know. So hopefully that helps, Lily. I do appreciate the comment. Jay Manga said, I have SI joint pain and I cannot do a hip hinge. What do I do instead? You learn to hip hinge. There isn't an option, right? If you're experiencing pain when you do a hip hinge, it's like, what point do you get the pain, right? Is it here? Well, if it's here, you need to start learning, right? So you're probably engaging incorrectly, right? So what's probably happening is you're standing up tall. I'm just moving the shirt so you can see my back. You don't do the hip hinge like this, it's just for visuals. You're probably doing that, right? That is not a hip hinge, that's bending, right? You need to do that. Now my spine's not moving. So maybe you hold on to something, right? And you practice it. Maybe you use the band variation and you practice it. You need to practice it. You're not going through a day in your life without doing a hip hinge. And it's very likely you get improvement from the thing that you can't do that is essential that you need to learn how to do. And so all you're doing at the moment is when you're doing a hip hinge, you're doing a bend most likely. And that's messing up and creating aggravation. So you go back. That's why we talk to our members about this all the time. Whenever you're doing exercises, your rehabilitation exercises, you are looking for aggravation-free reps. It does not change the current level of pain or symptoms that you are experiencing. And with the correct choreography. When we experience pain, we have violated one or invariably both of those principles. So we don't just do a different thing. You don't do something you can do instead. You figure out why you can't do this and you learn how to do it. That's where improvement comes. People have it really on its head when it comes to back pain, right? You're struggling to get better, so you look for things you can do. Things you can already do not get you better, right? You don't go to Japan as an English-speaking person and go, do you know what? This communicating in Japanese isn't working for me. I'm going to speak in English instead. No, you learn how to speak in Japanese so you can effectively communicate, or some mechanism of doing that, right? I'm being a bit tongue-in-cheek. There are obviously get-arounds in that example. But the point is, the hip hinge is done every day, from the moment you get up in bed to the moment you go back to bed, multiple times. You don't have a choice. You have to learn how to do it. You need to do that safely. You need to do that carefully. You might need a bit more support and guidance in doing that, but that's what needs to be done. People keep on looking for exercises that I can do. Exercises that you can do don't change you. And that's something that really needs to be turned on its head. Very important. What other comments have we got here? Be Great has said, when I sit, should I keep my legs shoulder width or is it better to have a wide stance? I think you're majoring in minors right here. Focus on the rehab stuff, right? Whether you have your legs here or here is irrelevant. We're getting into details that really, we're focusing on the stuff that doesn't get us better. Neutral spine, that's it. If you want to have your legs wide, if you want to have them closed, you want to have them one like that, it doesn't really make a difference, right? We're focusing on the wrong sort of stuff. We need to focus on the neutral spine, that's it. And then we need to focus on doing our rehab. If you do your rehab, you can sit how you like, fun within reason, right? Focus on the rehab. That's what we can help you with. These other bits, I think we're majoring in minors, as I said. I have herniated disc. I got recommended to do sit-ups and bent legs and pillow under my back. Yeah, sounds about right, and you should not be doing that. What are the sit-ups doing? The sit-ups are creating an environment in which you can maximally stress the herniated disc. So when you do the sit-up, you do this, whoosh, boom. I mean, even to the point where you guys can see, right? Like, if I do that, like, that guy's gonna break. That's how I broke the last spine, right? By demonstrating these flexion things. But when you're doing the sit-up, you're just putting a massive strain through the lumbar spine. We don't need to be doing that. We need to focus on on neutral spine. That's what you're focusing on when you're going about your back rehabilitation work. Focusing on the neutral spine, very, very important. And guys, for those of you that have been struggling for a long period of time with your sciatica, with your herniated disc, you've tried exercises, you've been given stuff like that to do from D2439947, right? And you're doing the wrong sort of stuff. Go and check out the program. If you're on TikTok right now, you can go up to the profile page. There's a link there with a video that explains more about the program, helps you realize that sheet of exercises is actually not a rehab. That's just a shopping list of random stuff. And those of you on YouTube, I'll post it. I think I might be able to post it in the chat. Yes, I can. And you guys can have a look at that. There's a video there. It explains a bit more about the program, what we do, how we help you guys. And you know, you don't need to keep struggling. You really don't. What else have we got here? Is a bent leg raise good for herniated disc? Jeff, I would focus on doing things like the dead bug, the marching bridges, the core 5 that we talk about. The Rock, you're too kind. Thanks for the comment. Recovering from flare-ups since July. Cannot see myself doing a Jefferson curl. Nor do you need to. Don't. There's no need whatsoever. My physio said no sit-ups. Your physio is correct, Mary. You do not need to be doing sit-ups. Good to hear that your rehab is helping. I have a herniated disc. I got recommended. Oh, that's that one I've just done. Leo said, great information is insane. If you guys have real issues, you must. Oh, thanks, Leo. Appreciate that. I do appreciate that. What other questions have we got, guys? I have 3 bulging discs, inflammation. What can I do? There's 3 aspects of getting better with a herniated disc. And too often people want to focus on 1 and 2, and maybe the subsets of 1 and 2. The first thing is that you have to have education. The difference between John, who's got a herniated disc at 4-5 and 5S1, and Sophia, that has 3 bulges at similar sort of levels, is that John got better because he didn't mess himself up every single day. You're tripping yourself up so many times in so many ways. And I think Lily, in her comment earlier about having a herniated disc after pregnancy, after childbirth, like you realize, she's hopefully realizing right now, like, God, there's so many things I'm doing where I'm like, man, I'm just messing this disc up. I'm putting more strain on this herniated disc. Like, so much of the reason you don't get better is because you're doing things that you don't even realize are a problem. And so that's why education is so important. You live with you for 168 hours of the week. And so if you're not giving guidance on how to live in that period, principles, neutral spine, that kind of stuff, then you're just going to keep messing yourself up. And what is an hour visit to your osteopath or your chiropractor, or even half an hour of exercise a day? What is that going to do to offset if you're just going away and just continually undermining the progress that you're making? Very, very important. I use the example on one of the comments today. I said, imagine you've got some guys coming around to renovate the house. And they do the work. They build the wall, they do the plastering, they start putting the electric in. And every night you go and take a sledgehammer and you just smash things to pieces. That's the equivalent of what so many people are doing. And then they go, well, why is the renovation not complete? Why are we running late? Why have I still not got a house that's fixed? Well, John, it's because every night when we do all the work, you come in and you just smash it all to pieces and we have to start again from ground up. And so that's something to really think about, the education. And then the 2 parts of doing is the relief-based work, core relief work. And that is things that relieve the stress and strain on the lower back. They take pressure off, right? That's your bed decompression, your towel decompression, your lower body stretching done with a neutral spine, your contrast bathing, a little bit of walking. We touched on swimming earlier. Things that relieve the stress and strain on the lower back that do not violate the neutral spine and do not make the underlying problem worse. Very important. And they all have either direct or indirect benefits to the lumbar spine. Your treatment could also come under that category, by the way. Maybe you have IDD, or maybe you have laser, or maybe you have an osteopath or chiropractor or physio that does some elements of treatment on you. That would come under that category as well. And then you've got your rehab. Make no mistake, the rehab is the stuff that gets you better. This is what we would call the core 5, or in the program, it's the core phase 1, 2, 3, and 4, the exercises that you're doing there to objectively rebuild strength and stability into that spine, directly into that disc that's herniated, directly into those L4-5 and L5-S1 segments of the lumbar spine. That is measurable, that is progressible. That's what gets you better. So those 3 things, education, rehab, and relief work. You do that, you're going to do well. And that's what we do in the program. So link up there, link in the chat on YouTube, and that's what we do. What else have we got here? Should you be engaging the core even throughout the day? I think it's helpful. Like, we regularly say to people, like, while you're doing one of the demonstrations of good core technique. And for those of you interested in the core, keep an eye out for next week's podcast. It should be a very good one. You should be able to do the belly pop, right? So the belly pop is where I've got my tummy here. Relax, in, 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 in. We're turning the core on, now it's off. On, now it's off. A lot of people can't do that. It's not a foregone conclusion that you can. So when people are learning the core engagement, learning those early exercises, literally thinking about that regularly is helpful. It's not going to strain you, it's not going to exhaust you, but it is going to get you to practice something. And as you practice it, you get better at it. And as you get better at it, you don't have to think. People say sometimes, I was practicing my core engagement while I was at the checkout waiting, and they're there flaring the nostrils, going cross-eyed and stuff, right? Because, and I say that tongue in cheek because they say that, right? They say, I must look so strange while I'm doing it because I'm really having to think. The idea is that you don't have to think. that you can just turn it on, turn it off at any time. And that demonstrates we've got good control. And if we've got good control, we can start testing the system out with our rehab and pushing ourselves. Leo said, would you recommend single leg RDLs and squat variations as a form of progression? We use them, Leo, in the program as a step up and a single leg hip hinge or RDL as accessories. So they would come under the core 5, yes. So yeah, they're good. They're nice ones. What else have we got here? Do you think I might be feeling back in my thighs since they are numb? I might get the feeling back. Mary, I'm not so sure. I wouldn't say no. And numb and altered sensation are two very important distinctions. So, you need a little bit more information on that, probably beyond the scope of a live session to get that appreciation. But the most important thing to ask is, where are we up to in the rehab? If we're still messing around with 10, 15 kilos, or we haven't even started doing that on a squat or hip hinge, I'd say there's a very good chance that there's room to make significant improvement. If you're there and you're like, Mary, do you know what? You're doing a bunch of different exercises, you're doing maybe squats and hip hinges, and you're doing them with a good amount of load, 40, 50, 60 kilos, something like that, without any aggravation, and you've made some significant progress, we've got to think about some other ideas, perhaps. What could be missing in those sorts of scenarios? Is the numbness or altered sensation always there, or is it variable? All of these things play a role. I suggest it's most likely that that there is prospects of getting better, but I don't know what we're doing in terms of exercises. Why are lower back extensions good, but sit-ups are bad? Both movements are the same. No, they're not. The mechanics and load on those areas are very different. The position of the spine is very different. And back extension isn't something that we suggest is good. I'd say back extension is less bad than a sit-up, but they're very different. And that's just about understanding mechanics, right? When we are doing a sit-up and we are bending forwards and rounding the lower back, that is the polar opposite of doing a back extension and extending the lumbar spine. Very, very different, extremely different. Primarily, the biggest difference is in the fact that when we bend forwards, we do not have segmental control over the segments. And so what generally happens is we just fire strain through the injured segment as we do that sit-up. Are back extensions in a Roman chair similar to the hip hinge? Yeah, so Buddy, I'm not saying that in a funny way, it's Buddy the pork chop. Yes, so this is one of my big issues. Like you see stuff of a guy with a barbell on his back doing a hip hinge on the Roman chair, and it's like, how is that accessible to any human being? Like, it's just a hip hinge, right? When you perform the hip hinge, you can do that on a Roman chair. You can also do a hip hinge badly and round your lower back, as is sometimes instructed on a Roman chair. Not that we would advocate that, by the way. I think the Roman chair is just an unnecessarily... The most important thing about your rehab, which is why the specific exercises that we talk about are chosen, is that it's easy for anybody to do, it's accessible at any level, and it's minimally complex. If you have to wait until you've ordered that thing from Amazon that costs you X amount of pounds, maybe a lot more, maybe $100, something like that, and then you have to wait till it gets you, and then you've got to pick it up from the delivery guy, then you've got to assemble it, then you start your rehab, but you've got to figure out how to use the machine, and then you've got to get the positioning right and everything. Having used those machines, there's so much faff, so much opportunity for someone to accidentally get it wrong. And I'm not saying at all for one moment you can't use those and get better. But it's like, why are you making things more complicated than they need to be? It's just a hip hinge, only you've removed the ease of application to daily life by fixating your hips and whatever. It's just a completely unnecessary piece of equipment. And I think it's just one of those things where you add a bit of complexity just to make it look unique from a selling point of view, when really you just do a hip hinge, right? You just do a hip hinge, because that's so much more transferable to everything you're doing every day. Equally, the other concept of we have to make it safe and be responsible for the actual patient, the person that's not very good at this. Like someone mentioned earlier on, I think it was, who was it? It was on YouTube. Jay Manga. I can't do the hip hinge, right? So why is this relevant? Because if I can't do the hip hinge, I struggle with pain, and I'm strapped into this funny little piece of machinery. I'm on the verge of buying one just so I can show you guys what I'm talking about, right? And I'm strapped into this machine, and then I struggle to do the hip hinge, and I'm in pain, and I'm like, I need to stop. How the hell do I get out of this machine? I'm stuck. I've got the handles, yeah, but now I've got to get my leg out, and it's just the worst case scenario that something goes wrong, and you're in the hip hinge position because you're learning it. You're doing it in front of a chair, and you're like, oh, I've gone too far. Catch myself. Okay, I can square back up. If you're in that hip hinge machine, the Roman chair, it's a catastrophe if you fail, right? It can really create some trouble. And so it's just one of the things that our job is, if you've got experience in doing these things for a long period of time, is realizing, and I'm not saying others haven't, but is realizing what happens before you do the exercise. What happens when you fail at the exercise, and how can we minimize the cost of failure as much as possible? And so I think that the extension machine has no place. I think it's completely unnecessary. And that's not to say, very importantly so, that's not to say that it can't help people. And there aren't tons of people that get a lot of benefit from using it. But I think they're getting better in spite of using that machine when they could have just used the hip hinge. And sure, some people say, well, I tried a hip hinge before. It's like, okay, fine, sure. Like, the only thing that I really care about is that you guys get better, right? So that's why we do these lives, to help you guys. And that's my opinion. So I hope it makes sense. You know, and I know that there are people that use those that help loads of people. And is that more important? The most important thing is that people get better. So that's fantastic. But that's why I don't think it's necessary. And you won't really see me advocating for it. It's just unnecessary. I mean, you could do all sorts of fun stuff in the gym, but are people going to be able to do that from home? You know? Where are we? 5 minutes left, guys. I'm going to try and get through a couple of these. What have we got? Okay. Why do I feel the pain in my lower back when I tried the decompression? Some people do feel, this is the bed decompression, specifically. They feel an achy feeling. And the best way I describe it is when you stretch a muscle, you often feel a stretch, a sensation, right? And then we describe this as a stretch, right? I do a hamstring stretch and I can feel a sensation in the back of my leg. I might even describe it as a tight sensation. And so when we do the decompression in the lower back, particularly the bed decompression, like when we do the decompression in the other room, you can often feel the stretch or the aching in the lumbar spine if you get it just right. And that's something to kind of aim for. It shouldn't be terribly painful, but we should feel a little bit of aching if we're getting it just right and relaxing just right. Lucas said spondylolisthesis L5S1 with a labrum tear on the right hip, noticeably gaining weight. What can I do? You just got to start the rehab work. And that's a great example of how these things can co-occur, right? So many of us have an injury for whatever, whatever's going on in the lumbar spine, but we then realize we've also got a bad knee and we've also got actually our hips aren't very good. Why? Because the muscles that you're using, you're leveraging. Think about the squat we've talked about. Think about the hip hinge we've talked about. All of the muscles that we are training when we're doing those movements. Let me just check I'm a human. Any moment now. All of the muscles that we're training in those movements are training to improve the health of the hip. They're training to improve the health of the knee joint. They're training to improve all of those muscles. And so the same stuff we've been talking about here, Luke. Focusing on your spine stability work, your dead bugs, your micro bridges, your squats, your hip hinges, and step ups, doing relief-based work. That is really important. Really, really important. If we're just doing a workout, that's not rehab, right? We need to do some rehab. We've got a spondylolisthesis down there. I want two things for you to do, Luke. Number one, after this, send us a DM, because I'm going to be wrapping it up pretty soon. Send us a DM, and we'll send you a link to asking for Janet's story, because she's got a spondylolisthesis, and she did really well. She was featured in one of the magazine pieces over here. I've got her on the wall just out there, but I can't show you guys now, so I'll just send you a DM, mainly because the camera's plugged in up here, and I'd take TikTok over there, and you guys would just be left staring at an empty room. So send us a DM for that. And the second thing, Luke, go and check out the program, because that's that gives you what you need to do. What other questions here? Maybe wear a back brace when sitting down. Do not use a back brace. Back braces are a bad idea. So on the topic of back braces, when we wear a back brace, those of you guys that are on TikTok, because you see a lot of comments coming in on there, right? Everybody, L5S1, L45, L5S1, L45, L5S1, L45. Why? Because that's basically what 90% of people, 95% of people that have back injuries and sciatica have, right? It's these last two here. If we take the human spine, when you wear a back brace, assuming that you are a skeleton like this guy here, the lowest you're going to get the brace is going to be the L4 vertebral body, maybe to the disc. And so the brace is going to work here. Most of us are not like that. We're carrying a bit more fluff around the sides. So the brace is probably up here in the upper lumbar spine, which means that assuming it does work, and I'm not really sold on the braces at all, for anyone really, aside from obviously the powerlifter that's competing in a world stage or whatever, assuming that it's actually working, it's bracing this section, not the section that's actually injured. So then all that happens is this doesn't move and this moves even more. At the Simplified Strength seminar this weekend, Sean said something very wise. He said, his opinion on belts, you earn the right to use a belt when you don't need it. And for reference, as I said in the article that's coming out next week, he did a squat raw, no belts, no nothing, 220 kilos. He doesn't need a belt, but he can use one and he can push his squat up to 300 kilos from what I've read online, which is really cool. if you don't have the vulnerability to move your body in the real world, a belt is only going to make you worse, I would argue. And one thing that's very, very clear is it feels nice when you wear them. I do not say that they do not. They feel nice when you wear them. But you are creating a slippery slope. And that's just the same. Like, we're looking for ways in which we can game the system to keep doing bad stuff as much as possible. And that's not what we want to do. Take a step back, do the rehab work, and build from there. And then you won't need to use these funny things. Bulging disc L4-5, pain in my, exactly what I said. Most of you guys, L4-5 and L5-S1. Why do I feel pain in my lower abs? Feels like a bruise. That, I'm not so sure. Typically speaking, you don't tend to get pain in that area. If it's the lower abdominal region, the lower right quadrant, and you're getting it at certain times, I would just get that investigated. We want to think in pain in this region here. So we get the bony bit on the side, talking about kind of here on the abdomen. You're thinking appendix. So just getting that checked out might be worthwhile. It might be just you could have a back injury and have a headache at the same time. You could have a back injury and have something else going on at the same time. There could be something else going on there. So it's just worth checking that out. It might be unrelated, especially if it feels like a bruise. So please, in my bridal era, just have a think about that and maybe take some action on it just in case. It's better to do it and not need it than need it and not do it, you know. Pain, move, shoulder to leg. I'm not so sure on that, Fearless. So you don't recommend those belts? Yeah, don't use them. Don't use the belts. Learn to do it yourself. Brad has said, should I avoid getting back on the bike until I'm completely pain-free, or start as I'm healing and keeping up and keeping aware of the curve? Brad, a couple of comments here. Number one, I always ask, and maybe give us an update in the members area. In fact, do give us an update in the members area as to where you're at on this, but what are you squatting, what are you hip hinging? If we're not at good levels and we haven't made some good progress in there, I think we're putting the cart before the horse, getting back into biking. Because, especially for guys, for obvious reasons, it's fundamentally, or practically, unless we're in a very, very upright bike, and even if we are, I'd still question it, you know, it's very, very difficult, near on impossible, to sit in a way that is actually with a neutral spine. You just can't. You really just can't. There's going to be some element of flexion over. Now, it's flexion with less load, so fair enough, right? And if we're just looking to, like, you know, cycle around, you know, the town for, you know, 20 minutes or something like that, then fair enough, right? That could be okay. But I would really focus on making sure that we're at a good level. So for me, really, it's a non-negotiable to being kind of at phase 4 of the program, Brad, and making some good progress there on the loading before we start thinking about other things to add in. So that's really where I'd go. Just because of, and also it depends, and let me know in that comment, Brad, what type of cycling you're looking to do. Because if it's road bike cycling, it's kind of like, yeah, leave that for a while. Just leave that for a while, please. Focus, if you've got extra time, focus on making more progress on the rehab work. Focus on making more progress on the strengthening. Focus on those other things instead, so we can really rebuild resilience. And then it's going to mean that if we want to get back to that kind of thing, cycling, and it's really important to us, social, all of that kind of stuff, then we can think about a strategy to do that. So let me know on that, Brad, because then we can come up with some creativity to figure it out and how it's going to work for you. You know, simple things like adjusting the height of the saddle relative to the seat, all that kind of stuff. Sorry, the saddle relative to the handlebars and all that kind of stuff, and we can go into granular detail there. So let me know. Martin has said, I have a slip disc at L5-S1. I got 8 injections. I am without pain for now. That's awesome that you're without pain, Martin. We have to remember that when we have the injections, I'm assuming they're like steroid injections, etc. If you jab someone with enough injections, then fair enough. That's fine. But the understanding is that the injections do precisely nothing to heal this. What they do is, in this scenario, make you not feel the pain, which is great, one could say, although I maybe don't quite agree that is actually so great. Make sure you're doing your rehab. Because if we've just juiced ourselves up to the point where we have put a good number of injections into the back to eliminate the pain, and then just that's it, that's not it. We should be given rehabilitation support to really rebuild strength, resilience into the back. Otherwise, we run the risk of going, oh, I did this injection 6 months ago and it didn't work, so my back pain came back and it came back worse. Why? Because the rehab hasn't been there. The rehab is the foundational. We've got rehab. The pyramid is that base of education and rehabilitation exercises to build resilience. And then at the top, we've got that pyramid of, you know, the whatever procedure we're going to have, whatever treatment we're going to have, whatever therapy we're going to have. Do injections do damage to the tissues over time? There is some, if you look at some of the research of injections into shoulder tendons, because there's a lot on that, steroid injections specifically, creating this window of increased chance of ligament or tendon rupture post-injection. I don't know that it necessarily has a long-term effect, but it does seem that it's something that you need to be discussing with your practitioners. Now, they will often say, your surgeon will say, oh, look, we can only do a couple of these and then we're going to have to not. But I think generally speaking, we want to be mindful about leaning on injections. They can have a role, but most of the time we see you guys commenting about having injections. It's a case if you had an injection and it's been implied perhaps that the injection is the thing you're having, rather than the injection is a very, very, very small part of a wider rehabilitative strategy to help you get better. And that's often not communicated effectively. Can we recover from a disc bulge and disc herniation from your exercises? That is literally what everyone in the program does. So yes, that's the idea. That is the idea. Brad has said, thanks. I replaced the handlebars to have me sit up straight. Good. Need to bike around town, not spot. Okay, great. Yeah. Yeah, Brad, at phase 2, I'd say it's a bit premature, but you're going to be out. We do lots of things. You might have seen the earlier on Lily talking about having a 12-week-old. She's going to be doing lots of stuff that I would argue is worse than a little cycle around town. So it's just understanding and appreciating. You're educated now. You know about this kind of stuff. So it's trying to be cautious, careful when you get back in from doing that little cycle. You do a bit of care of self-relief stuff, right? Maybe use some contrast bathing, a little bit of towel decompression, bed decompression to offset that necessary activity, let's say. And we try not to get carried away. That's probably what I'd say to help you, Brad. And you're obviously making the right move with regards to adjusting the handlebars side of things. Mejel has said injection versus oral steroids for rehab. I would say no. I just say no. They're not rehab. I would really be very, very reluctant to be taking oral steroids. There's always a trade-off whenever we're doing anything, guys, and I would suggest that that's probably not worth it. What else have we got here? Does your core 5 also? So Dean has asked about thoracic spine pain, and really most of the stuff is focused around the lower back, right, guys? I'll be honest with you. It's focused around the lower back. That being said, if you are building up a strong squat or hip hinge and those other sorts of things, then it's going to help your thoracic spine, because by definition, you're going to be doing things activating and engaging those muscles as well. But it's more of a second order benefit. What else have we got here? I have a problem for 8 years of disc bulge. Yep. We've got a lot of people that come through the program. Many, many people. We've had, I think, one comment here where, well, no, even that comment wasn't actually real, because they'd had problems preceding that episode of back pain with the glute, as we discussed at the start of the live. So yeah, I wish we had people that had just injured their back, but most of the people that ever come to the program have had back pain for months if they're lucky, but more often years, and often decades. They've been struggling with these things. So you're in good company, Nomi. Towerpot's family said, I've been told to do a Romanian deadlift. It is the same as a hip hinge, yes. Yes, guys, the reason we call it the hip hinge, I mean, this is just the way it is, because it calls it what it is, right? If people say hip hinge, it's like, what am I doing? You're hinging at the hips. Whereas if I say Romanian deadlift, two things happen. Number one is like, I'm not doing a deadlift, I've got a bad back. That sounds scary. And number two, you go, Romanian what? Like what? It doesn't make any, they don't know what it is, right? So a hip hinge is easier to communicate to people, but yes, a hip hinge is a Romanian deadlift for you guys. What else have we got here? Guys, I'm gonna wrap it up now, I think. Yeah, oh gosh, I've gone over. Do you do relief work when you don't have pain? I will finish on that question. Thank you. That is a good one. Yes. The idea is that with the core relief work that we talk about, lower body stretching, a little bit of hip mobility work, right? The towel decompression, the bed decompression, they are long-term healthy back practices that we should be doing, right? Where as a people, generally, we are too inactive. We probably don't have the appropriate level of hip mobility. If you do have good hip mobility, if you're a hypermobile individual, then the hip mobility stuff is a little bit less relevant, right? But for most of us, or a good number of us that don't have hypermobility, continue to do a little bit of stretching on a daily basis is helpful. It's not that time consuming. Continue to do the bed decompression, the towel decompression to offset the stress and strain of daily life is a helpful thing to do. So the idea is that they are a long-term practice. And Mel, about the discectomy, in fact, I'll finish on this one because I like this question. When we've had the discectomy, often we are in the most vulnerable period afterwards, right? Yet we get the least advice. The advice is, I'm going to be really, really specific before we have your surgery. This is the surgeon talking to you. Really, really specific. We've got to do this, we've got to do this, we've got to do this, all this kind of stuff, right? And then we have the surgery and it's like, you're on your own for 6 weeks. And then you're going to have physio and you're going to have some, what should be, really, really specific advice. So in the window that you're most vulnerable, the advice is don't lift too much, keep walking, don't sit down and don't twist. Like that makes no sense. The time when you need the most advice. And that's why we talk about doing the rehab work immediately. Because if you've been cleared to get out of the chair, to sit in the car, to go home and be amongst yourself, then you're already doing stuff that's more challenging than carefully approaching the rehabilitation that we talk about. So it's something to think about. And if any of you guys are lining up any kind of surgeries or anything like that, you know, ask your surgeon. Say, hey doc, look, we've been really specific leading up to my surgery and you're telling me I got all this stuff, but I'm in this window where you're giving me no instruction and I'm at my most vulnerable. Do you have anyone that you could recommend that might be able to give me some more advice? And that, quite frankly, is why we get a lot of members that get referred more and more from surgeons specifically. Because they're like, well, I don't have the expertise. I'm a surgeon. I do surgery. But I know these guys that can help. So hopefully that's helpful, guys. If you need any more help, check out the link in the profile page, those of you on TikTok. Nomi has said, not everyone can afford the month-long membership. I appreciate that, Nomi. The best thing I can recommend to you would be join the month. Like, one of the things with the membership, guys, is we don't have any funny contracts or any of that kind of business, right? It's like a Netflix subscription or your subscription to Amazon Prime. You join, you stay for as long as you need it, and you can cancel any time. As long as you cancel it before the next renewal or turn off the auto renewal, no problems, right? It's super easy. So if you want to join for a month, follow the material for a month, then go off and do it on your own, and then come back in 2 months' time and do a bit more like we have many members that dip in and dip out and do that. If finances are an issue, right? That's perfectly reasonable to do. Use it however you want. And you're not tied into any funny business. If you decide that, you know what, I really like what these guys do and I really like the program and I want to keep access to it and you don't want to spend more than you have to, then there is the yearly option that you can subscribe to, which saves you 25%. Yes, it's an upfront payment, but it saves you money. So hopefully that makes sense. And no, we won't be adding a 7-day program, I'm afraid. We do so much stuff online that is freely available, like these lives. You know, if you need to save up to join, you're more than welcome to. But just adding extra layers of complexity, having people jumping in every 7 days, that's not something that you want to do. So I do hope that helps, guys. I hope you understand. And yeah, thanks for joining. See you next time. Guys on YouTube, I will be looking at probably doing another live tomorrow on Friday. So I hope it helps you guys. Have a good one. And Mejul, yes, we just have one. We have one membership. It's the premium membership. That's it. I'll put a link down here again for you guys on YouTube. Let me just turn that down. That's TikTok finishing. Check out the video there. If you like what you see, crack on. I have to put you on slower speeds as my brain doesn't work as fast as you talk. I'm sorry. I get too excited when I'm doing these, and I just speak too quickly. It is something I am sincerely trying to work on. But, you know, it happens. Laura's always telling me to speak more slowly. And hopefully you'll notice there are periods where I actually do talk a little bit more slowly. But yeah, it's just, let's call it a character flaw. I'm working on it though. I am working on it. It's just so much, like when you've got all these comments coming through and you're trying to help everyone and answer all the questions. I'm like, if I talk faster, I'll just help everyone, right? But it kind of doesn't work like that. Unfortunately, if I talk too quickly, so hopefully you can watch it back and turn the speed down. Maybe if there were some parts that you missed. So yeah, awesome. Thanks guys on YouTube, and we'll see you next time. Take care.